As mentioned, I'm Harry Raju, also trained at St George's. I'm going to be talking about bradycardias in the athlete. So, over the next 20 minutes, I'm going to give you a little bit of the background of the science and the research that supports the finding that bradycardia is a physiological adaptation in athletes, and tie that in with how that impacts on the athletes that we look after. But the bulk of my talk is going to be examples of bradycardia in athletes and how to avoid the pitfalls in diagnosis and management of these individuals. And again, I'll try and link that to some of the guidelines, mainly focusing on those from the European Society of Cardiology relating to athletes and to arrhythmia management. So, firstly, the research. Well, you've seen a slide like this earlier today. And essentially, we all recognize that electrical remodeling forms part of the spectrum of physiological adaptation in athletic training, and bradycardia is a manifestation of that. There are two main hypotheses that explain this bradycardia in athletes, and the oldest and perhaps most well-respected is that relating to autonomic tone. We know from multiple studies that athletes have a high vagal tone and perhaps also demonstrate a slight reduction in their resting sympathetic tone. And this is further evidenced by their heart rate variability being increased, often seen as sinus arrhythmia on an ECG in athletes. However, more recently, there is a growing body of evidence that suggests that athletic training also causes intrinsic changes within the conduction tissue of the heart in these athletes. And this is perhaps best illustrated by this Brazilian invasive electrophysiological study of 6 athletes indicated in the solid black lines on these graphs, and 6 matched sedentary, untrained individuals in the interrupted lines on these graphs. And what this shows is that irrespective of which invasive measure of sinoatrial function or atrioventricular conduction, athletes have a parallel response to chemical autonomic blockade. So in the center, we have the action of atropine, that is parasympathetic blockade, and on the right-hand side of each of these graphs, the action of beta blockade. But perhaps more importantly, even with complete chemical blockade of the autonomic system, athletes still have slower conduction and lower heart rates than individuals, suggesting that there is an independent or intrinsic reduction in heart rate in athletes that is independent of autonomic function. So, why does this matter to the athletes that we're looking after? Well, these relatively acute physiological adaptations are reversible, and we see that very clearly from controlled animal experiments in rats predominantly, which show that within 2 weeks of detraining rats, we see complete resolution of both the autonomic heart rate adaptation, but also the intrinsic heart rate change. In humans, we don't have quite so controlled studies, but there are multiple observational studies that suggest that this is also the case in humans, although perhaps only partly reversible. With chronic or long-term endurance athletes, the issue is less clear. Certainly, a study of a little over 60 apparently retired endurance cyclists showed that they demonstrated conduction disease in comparison to matched golfers. And by that I mean they had lower heart rates, longer QRSs, and more asymptomatic sinus pauses, certainly a higher prevalence of that, although the interpretation of this is somewhat complicated by the fact that despite being retired, they were all still training over 4 hours per week, and a majority of them used performance-enhancing agents, the effect of which we can't discern. Nonetheless, detraining could be considered in these individuals. So now I'm going to move on to the bulk of my talk and just show you some of the examples that we see as part of our screening program in young, predominantly asymptomatic athletes. And as the previous talk said, these are all in individuals aged between 14 and 35. So I'm sure you've all seen examples of sinus bradycardia or first-degree heart block. These are changes that have been listed in the ESC consensus statement as being so-called group 1 changes, common and training related. And both of these rhythm strips are from elite endurance cyclists, with the top one showing a heart rate of 38 and the bottom with a heart rate of 40. And often the two things coexist. These abnormalities on their own require no further evaluation except in the context of symptoms, obviously. However, sinus bradycardia can manifest itself in a number of different ways on a surface ECG. And this is one example. I'd like to just draw your attention to the inferior leads on this, if I can, yep. Inferior leads here, where you can see an inverted P wave and a measured very short PR interval. And if you look at V1, you see an absence of an isoelectric line between the P wave and the QRS, which could be interpreted as suggestive of pre-excitation in this individual. However, a very simple maneuver here, repeating an ECG after exercise, will increase the sinus rate in a normal, healthy athlete, and this changes your P wave to be upright in lead 2 and returns the isoelectric line in lead V1 with a normal PR interval. And this is a useful, simple maneuver that can be done with a standard 12-lead ECG. Another simple maneuver that can elicit sinus rhythm from relative bradycardia in an escape rhythm such as this, we again have, this is a rhythm strip of someone going from supine to standing. And again, you'll see inverted P waves here in lead 3, and within a 10-second rhythm strip, the act of standing then moves these P waves upright, again revealing normal conduction. Escape rhythms can originate not just from low in the atrium, but from anywhere. And again, this is a rather nice example of, sorry, for some reason, the rhythm strip is rather pale on this. But if you look closely at the rhythm strip, you'll see 2 sinus beats followed by junctional escape beats and a return to sinus as the sinus rate increases. However, I would like to draw your attention to what may be interpreted as unusual repolarization anomalies here, and again, possibly misinterpreted erroneously as pre-excitation, but of course, with careful interpretation of this ECG, you'll see that each of these red circles indicates atrial activity, and in fact, your escape rhythm is now faster than your sinus rate, which causes functional AV dissociation. Of course, it's important not to interpret this as heart block because your escape rhythm is running faster than your sinus rate. Again, exercise would be expected to normalize this. So, the ESC Sports Nucleus document on ECG interpretation recognizes that bradycardias of around 30 beats per minute and asymptomatic sinus pauses are recognized in athletes, as are escape beats and escape rhythms with functional AV dissociation, and alone don't necessarily require further investigation except in the context of symptoms. They do recommend, however, that anyone with a resting heart rate of less than 30 beats per minute and significant pauses in the daytime, that is 3 seconds or longer, are evaluated to ensure that there is no evidence of sinus node disease. In athletes, this can be done relatively easily by ensuring the absence of symptoms and with simple maneuvers such as exercise. And if absolutely necessary, detraining can also return to normal conduction state. An earlier document that looked at arrhythmias specifically in athletes recommends annual follow-up of those with significant bradycardias, but more frequent follow-up and review in the context of symptoms that requires detraining. I'm going to move on to another case that demonstrates bradycardia as well. This is a 17-year-old boy who's both swimmer and endurance cyclist with a heart rate of 40 beats per minute. I hope you will all recognize that the electronic interpretation at the top here, suggesting this is sinus bradycardia, is completely incorrect. And again, if you focus your attention on the lead 2 rhythm strip at the bottom, it's fairly clear that this represents 2-to-1 AV block, with each of the P waves in a green circle conducted to the following QRS, and each of those in the red showing a complete non-conduction. In this situation, as with apparent sinus node disease, simple maneuvers such as exercise can help, and again, in this screening, with relatively minimal exercise, these two different ECGs are recorded from the same individual, and you'll see on the top a very nice example of Mobitz 1 or Wenke back block with progressive prolongation of the PR interval from the green circle through to block at the AV node at the red circle, and in the lower ECG with only a slight change in the sinus rate, evidence of first-degree heart block. We did perform a Holter Monitor on this individual as well, which showed a variety of different degrees of AV block from first degree to Mobitz 1. And on the right-hand side, in those circles, you'll see a nice example of what's often referred to as paired beating, which is one of the classical footprints of Wenke back conduction. So, when you encounter an apparent AV block in an athlete, it's important to ensure that the block is extrinsic or autonomic in etiology rather than true intrinsic conduction disease. And the reason for that is that infranodal or intrinsic conduction disease is associated with a risk of sudden cardiac death. In our individual, there was no evidence of any widening of the QRS, no evidence of any interventricular conduction delay, but perhaps most importantly, we had increased conduction, improved conduction with improved sinus rate and with adrenergic surge with exercise. Generally, those that have vagal AV block have a variety of different degrees of AV block, that is first degree, Mobitz 1, and also, in this case, Mobitz 2, and often it coincides with the occurrence of sinus bradycardia. You'll recall that this particular case had evidence of 2-to-1 block with an atrial or a sinus rate of 80 beats per minute, and while that is relatively unusual, it's not unheard of, and about up to 1 in 20 individuals will have a predominant AV effect of their parasympathetic system over their sinus node, and it's important to be aware of that and not interpret this as intrinsic disease erroneously. So this individual can be, on the basis of these investigations, can be safely reassured that this is all physiological adaptation. The ESC document again recognizes first degree and Mobitz 1 as training related and relatively common, but also states that higher degrees of AV block, that is second degree Mobitz 2 or complete heart block, should be evaluated carefully, as we have done in this individual. Again, the arrhythmia guidance suggests that pacing can be considered for higher degree block, and that those with ventricular pauses of more than 3 seconds or ventricular response rates of less than 40 again be evaluated very carefully before it's attributed purely to training. I'm going to move on and give some examples of screening from or ECGs from some older endurance athletes, because these individuals often cause a bigger diagnostic and management dilemma for us. The first of these is a 62-year-old lifelong marathon runner who came complaining of exertional pre-syncope relatively late during his training period. So, for example, between 10, 15, maybe 20 minutes into a run or during cycling. And I'll steer clear of the other minor repolarization anomalies and stick with heart rhythm issues with regard to this case. His CMR was essentially structurally normal apart from mild biatrial dilatation. So he came, and while we performed a Holter monitor that showed significant nocturnal pauses of up to 5 seconds and daytime pauses of 2 seconds, he rather helpfully was able to document his own pulse during a training session using a wrist heart rate monitor. And if you can see here, he is able to he was able to document precipitous falls in his heart rate during treadmill exercise and during cycling that corresponded with his pre-syncope. In someone who's symptomatic, the decision-making process is perhaps a little bit easier in that something obviously needs to be done about this. It would be reasonable to consider pacing, and I just bring in at this stage the very recent ESC pacing guidelines. So this document doesn't specifically relate to athletes, but it does recognize and acknowledge that sinus bradycardia is a physiological adaptation in trained athletes. And it also suggests that pacing in sinus node disease, even if asymptomatic, is reasonable, although not in young trained individuals. For this particular patient, I'll take you back to the issue of reversibility, and we would always consider detraining in such a person to see whether this resolves their apparent sinus node disease. However, for those of you who look after lifelong or veteran athletes, I'm sure you'll agree that it's incredibly difficult to persuade these people to detrain even over short periods. And so after consultation with him, he agreed to have a pacemaker fitted. I'm now going to move on to what's going to be my final case, and this is a 49-year-old veteran triathlete, so again an endurance athlete who I put his rhythm strip at the top, came in with sinus bradycardia, and relatively unremarkable initially, although further monitoring of his ECG showed in the lower half of this screen what appeared to be significant AV block. At first glance, certainly I looked at this and thought, well, this looks like a non-conducted P wave down here with relatively constant PR intervals before and after, which I would have interpreted as Mobitz 2 block at first glance. And here on the right-hand side, we have 2 consecutive non-conducted P wave suggestive of advanced second-degree heart block. I'd like to go over this in a little bit more detail with you. So looking at the left-hand side, so the single non-conducted, I've blown this up a little bit here. I've marked with dual green arrows. These are all equidistant from each other, just to show you that the PR interval for each of these is relatively constant, and perhaps, if anything, the first return beat over here has perhaps a slightly longer PR interval. That in itself essentially rules out Wenckebach or Mobitz 1 block. However, more interestingly, from a diagnostic point of view, and something that's important to look at, is actually the PP interval in this case. Each of these red lines is, again, of equal distance, and you'll see that the PP interval, as you approach the period of AV block, lengthens, and it shortens again as conduction returns. And this is important. This particular phenomenon is often described as pseudo-Mobitz 2 block. The reason it's pseudo-Mobitz 2 is because classical Mobitz 2 requires a fixed PP interval. The sinus rate should not change, and often people will say that any variability of more than 40 milliseconds in the PP interval questions whether it's true Mobitz 2 block, and certainly this individual had variation of the PP interval during this of up to 500 milliseconds. So what does this tell us? Sorry, just to reiterate that this wasn't just an optical illusion. We did digital caliper measurements of all of these, and the PR interval is relatively constant, and the PP interval does indeed extend at every point where there is AV block and shortens again at the return of conduction. So what does this tell us? Well, this variation in the PP interval is highly suggestive of this being vaguely mediated, which again is benign. In AV block that occurs with bradycardia, it is almost exclusively vagal. However, as in everything with medicine, there is always a caveat, and there is a condition called pause-dependent or phase 4 AV block, which should be differentiated. In very simple terms, the major differentiating factor is this, that if you have gradual PP and or PR prolongation at the beginning and end of the period of block, it's almost certainly vagal. And whereas if the onset of block and the restart of conduction coincides with an ectopic from either atrium or ventricle or anywhere else, the possibility of pause-dependent paroxysmal AV block must be considered. The reason for that is pause-dependent block is also related to infranodal disease and is potentially a cause of sudden cardiac death, which must not be missed. I'm coming to the end of my talk here, and I'm just going to summarize a few things. Firstly, when encountering an athlete with bradycardia, the first thing to determine is where is the bradycardia originating from. Sinus node is relatively benign, and in the absence of symptoms, and certainly if sinus node function returns with simple maneuvers such as going from lying to standing, increasing the heart rate with atropine or with exercise, these individuals can be reliably reassured. For those who have apparent disease in the Purkinje system, these disorders are generally associated with sudden cardiac death and need to be evaluated very carefully and considered for pacemaker implantation. In those individuals who have AV block where it's not clear exactly where the level of block is, careful evaluation of non-invasive investigations and evaluation with maneuvers such as exercise, atropine, and carotid sinus massage can be very helpful and generally negate the necessity for invasive EP study in these individuals. And I will just add one caveat for EP studies. It has been documented that athletes can have slightly prolonged normal conduction intervals, and so the interpretation of these studies can be equally difficult as with the surface ECG. So the main considerations are in those people who have symptoms directly attributable to their bradycardia, where there is symptom arrhythmia correlation, it is important to consider therapy. And in the first instance, detraining may be sufficiently effective. However, they may also choose or benefit from pacemaker implantation. Even in those people who are asymptomatic, evidence of any His-Purkinje disease should again warrant careful consideration for pacemaker implantation. And a small minority of individuals may have a family history that is suggestive of an inherited heart disease, of conduction disease, and again, these individuals need to be studied carefully. But the vast majority of athletes who are asymptomatic or whose symptoms resolve with detraining can generally be reliably reassured following careful evaluation of non-invasive electrocardiographic study. I haven't in this talk gone into other associations such as atrial fibrillation in any detail. Again, there is a suggestion that conduction disease predisposes you to atrial fibrillation later in life with training, and I've also not talked about structural or functional disorders which anyone can suffer from, as well as potentially athletes, although less likely to be elite athletes. So in conclusion, in general, there is no such thing as too slow in an athlete, although very, very bradycardic patients should be evaluated closely on a case-by-case basis, dependent on the type of arrhythmia, the level of block, the age of the athlete, and the level of training, as well as, if necessary, their response to detraining. With regard to their long-term outcomes, it appears that chronic endurance training may predispose people to conduction disease and also potentially atrial fibrillation, although that's not that clear. Thank you very much for your attention.